this, we're taking 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 with a pinch of salt.
Hello, ladies and gentlemen, and welcome to another episode of A Pinch of Salt, the ERA podcast that tries to ask common, clinically relevant questions to provide you, our audience, with clinically relevant answers. My name is Andrej Kobernet. I'm a nephrologist from Slovenia, and this is the episode on primary hyperoxaluria type 1, or PH1 as it is sometimes referred to, a rare but devastating disease. For those of you who might not know this disease well, this is a genetic disease where too much oxalate is produced endogenously, which leads to calcium oxalate crystallization, kidney stone formation, nephrocalcinosis, kidney failure. And after kidney failure, all of these calcium oxalate crystals are deposited in various tissues around the body, in bones, joints, the heart, and vessels. So the patient is quite literally, and I mean this quite literally, turning into stone. A very unfortunate situation. Luckily, this is also a disease where we have a new and very successful therapy, I would say. And to talk about all of this today is Justine Bacchetta, a very well-known expert on PH1. Justine is a pediatric nephrologist, head of the pediatric nephrology unit and vice chair of the Department of Pediatrics in Lyon, France. Justine, welcome to A Pinch of Salt.
Thank you so much for the invitation. I'm really happy to be there.
We're very happy too. We're happy that you're a pediatric nephrologist who has devoted a lot of time to this. But before we start with the first question, I have to say I'm an adult nephrologist and I like to work with kidney stone patients, but I was unaware, I have to admit, before, not so long ago, that this is not just a disease of pediatric patients, but actually that there's a number of adult patients, and that the median age when dialysis is started in patients who do come to dialysis is about 27, which actually means that half of them are older than 27. So this is definitely something that we should think about, and actually even, I would say, actively find these patients in our dialysis units. So especially now that we have some more specific therapy. So I guess the first question I wanted to ask is, how do we, as adult nephrologists, how do we identify these patients, particularly ones who are already on dialysis and who are perhaps being prepared for transplantation?
Yeah, so this is a very good question and a very good comment that some patients in adults can reach dialysis. But what I would like to say is that it's a problem, I think, everywhere in Europe and in the world. And before the era of these new therapies, we performed a study in France showing that the diagnosis delay for PH, not only PH1, but PH1, 2, and 3 in adults was 25 years. So, it's a huge diagnosis delay. So it completely fits with your comment. And that said, indeed, some patients may reach dialysis when they're adults, but they may have been presented symptoms in childhood. And I think this is important to search for consanguinity, to search from early kidney stones in life, to search with recurrent and bilateral stones, and to search for associated nephrocalcinosis. And if you have that, you may say that maybe it's not a primary hyperoxaluria, but maybe it's a genetic stone disease. First thing. And then specifically for PH1, you may also have systemic oxalosis. So you may have patients with severe anemia that you will not understand, patients with severe hyperparathyroidism that you will not understand because of fibrosis in the medulla. And you may also have patients with unexplained fractures, bone pains, bone deformations. And in such a case, you really have to wonder whether it's PH1, because if it's PH1, you will really have to modify your management to propose intensive dialysis and obviously to propose RNA interfering therapies.
So these are the basic clues, right? Early kidney stones, consanguinity, nephrocalcinosis, unexplained pain, unexplained anemia, severe hyperparathyroidism. So we should think about this when we do our rounds in dialysis units. The phenotype is not always the same, right? Not all people have kidney stones or a lot of problem with kidney stones. Some just have nephrocalcinosis, right? It's not mandatory to have many kidney stones, right? It's not always the same case.
It's not always the same case. You may have a huge variability, especially even in the same family. In a same family with the same mutation, some patients may present with infantile oxalosis, and some of them with only kidney stones.
Yep. So we've gone through the clinical picture, probably the most important part. But now that we have the suspicion, how do we have the diagnosis? How do we test? Do we do genetic testing, especially perhaps in Europe where it's more widely available? Because it used to be measuring metabolites of oxalate to get the diagnosis, glycolate, and so on, and very few labs do that. So what would your suggestion be to people who are not in dedicated centers? How do you diagnose primary hyperoxaluria?
Yeah, this is also a very good question. I think we are lucky to be in Europe and to have quite easy access to genetics. So I would propose to go for genetics because you may have pH, but you may also have some other genetic cause of stones, so that it can be important to have the diagnosis. And then if you perform metabolites, you may perform oxalate, and you may measure oxalate in the urine in a patient with normal renal function, or at least with preserved renal function. You will measure urinary oxalate and not plasma oxalate, because plasma oxalate levels, which I will refer to as POX levels, only increase in patients with advanced chronic kidney disease. So it's very important to keep in mind a patient with stones, with normal renal function. If he has normal POX, you cannot rule out PH1. Very important message. And then, in contrast, in dialysis, you will have increased POX levels, but you may also have increased POX levels in patients in dialysis without PH1. Also very important. And in diabetic dialysis patients, increased POX levels have been associated to an increased risk of cardiovascular death. So if you measure POX, you need to know your assay, and you need to know the reference value in normal populations and in patients also with CKD and advanced CKD, so that you can compare. So the question is, you can ask POX levels, glycolate, and the other metabolites are very scientifically interesting, but they are not available in routine, and I wouldn't fight to have these metabolites in all centers. I think if you have genetic and if you have access to urinary oxalate or POX, it's enough.
Yeah, that's great. And like we mentioned, the problem when you're on dialysis is that this calcium oxalate crystallization occurs in tissues, and these people have many problems, many pains, also die younger because of cardiovascular situations, because of calcium oxalate crystallization in the heart and the vessels. And the reason is that the dialysis regime, as it normally is not very good at eliminating the oxalate. So one of the things that we try to do when we fight for these patients is to intensify the dialysis regime. That's one thing. And the other is to give the specific treatment, which is lumasiran. Maybe you just mention what lumasiran does and also what the intensified dialysis regime should be.
Yeah, so lumasiran is an RNA interfering therapy. Today, it's only approved in Europe, but there is another one approved in the US, and we are waiting for the approval in Europe. It's nedosiran, but basically they block the synthesis of oxalate by the liver, and they convert into a non-toxic metabolic pathway. So what we have to remember is that these RNA interfering therapies only target the liver. And when a patient with PH1 reach end-stage kidney disease, he or she will begin to have systemic oxalosis and deposits of oxalates within bone, within vessels. And these RNA interfering therapies do not affect this part. They just block the liver synthesis. So even with RNA interfering therapies, you should still provide intensive dialysis regimen to to get rid of all these oxalate deposits in bone and in vessels to improve systemic oxalosis. And I think this is really important. So dialysis regimens should be as intensive as possible for as long as possible. And I think it's crucial when you are preparing your transplant strategy. But obviously, it induces a significant decrease in the quality of life of the patient because he or she has to go quite often to the hemodialysis unit. In children, we do 6 days per week. And in the past, we also combine PD to hemodialysis to try to improve the removal of oxalate. Now we just do 6 times per week of hemodialysis. And I think it's important to explain to patients why we ask them to do that. It's not to bother them. It's just to prepare as ideally as possible the transplantation. Everything you will have removed before transplantation will not go on your graft. So I think this is a very important message for physicians and for patients.
Yeah. So basically, it's like a dialysis regime for a pregnant patient, which would also be 6 times a week, perhaps, for as long as possible in a way. Because you mentioned already transplantation. Transplantation is the ideal therapy for these patients because nothing eliminates oxalate as good as a kidney. But the problem with the transplant is that if you have a lot of systemic oxalosis, then once you do the transplant, all of this comes out of the tissues and into the kidney. So that can ruin the transplant. That's what we're afraid of, which is why we treat them with lumasiran, one of the reasons, and why we do the intensified regime. So, for example, if we do find a patient, we do start treating them with lumasiran, we do explain to them the intensified regime, we do start doing that. Can we put them directly on a transplant list if they're already prepared, or is it good to wait a little bit for the systemic oxalosis to be improved, or does that not make sense? Just go for the transplant once you can.
Yeah, I think the answer is not yes or no, because it will depend on the patient, obviously. And also, it depends whether you diagnose, for example, a patient, you do your dialysis ward and you see a patient who has been on dialysis for 5 years. Oh, maybe he has oxalosis. And then for 5 years on conventional hemodialysis, he will have a huge systemic oxalosis. So maybe the answer will not to go to transplantation within 2 months, as opposed to a patient that is already diagnosed, that is evolving, that is already treated by lumasiran. Maybe you can be more proactive. I think the main thing is to anticipate everything for PH1. And in dialysis, if you begin, let's say you diagnose your patient in dialysis and you begin lumasiran at that time. Lumasiran, according to the product, you should give monthly infusions 4 times, and then you switch to quarterly, every 3 months injections. There is an amendment in the Illuminate-C study. So Illuminate-C study is an industry-sponsored trial in dialysis, and they showed that if you consider your POX control as insufficient, you can go back to monthly injections to try to control as much as possible POX. So probably you should wait to be in the maintenance phase and to see your POX levels under lumasiran therapy. And then the question would be, which is the safe POX level to go for isolated kidney transplantation? So it's what we try to define in our initial series of 5 patients. Then we first published in NDT in 2023. And in this NDT paper, we really reinforce the concept that we need to be proactive very early after transplantation. Within the first hours, first days after transplantation, we need to be proactive. And then we have the follow-up in the New England Journal of Medicine last year with data at 2 years. But the POX levels in these 5 patients ranged up to 72 micromole per liter of POX. So I don't say that is the safe threshold is 72. I only report our experience from 5 different centers in France and the Netherlands. We went up to 72 micromole per liter. But most importantly, you need to anticipate this kind of transplant strategy, meaning that if the transplant occurs during a weekend, you need to have discussed as a team what you will do during the first hours and eventually discuss with an expert center so that everything is prepared. Anticipation is key. And in this early post-transplant period, some people do some prophylactic dialysis. Some teams do not perform prophylactic dialysis and keep dialysis only in case of delayed graft function. Some teams propose early alkalinization, hyperhydration. Everything is described in the NDT paper, but I think the important thing is to anticipate and to warn the patient that a transplantation in PH1 is challenging and is not a conventional transplantation, that you will need to have a very proactive management for months after transplantation to stay on the safe side.
Yes, but I guess still the transplantation is still the best option because it eliminates, it's the best at getting rid of oxalate, much better than any dialysis method. Well, thank you for describing this, and I would really refer to our audience to these papers because there's so much great details in there about hydration and alkalization. So you already mentioned some centers do dialysis immediately after transplantation to try to avoid acute oxalosis, right? So we expect that when we do the transplant, a lot of oxalate will come from the tissues, and perhaps the kidney will be okay with eliminating that, but if there's too much, you will have acute oxalosis. So some do dialysis even daily and then check POX values to see how low, if they come below 20, where it's possibly safe. So, but you said you don't do that, right? You don't do immediate dialysis.
I'm a pediatric nephrologist.
Yeah.
So I think there are some differences between adults and children. And it's true that in Lyon, so we have the experience of combined kidney liver transplantation. Before doing this isolated kidney transplantation with RNA interfering therapies, we also had more than 20 years of experience in this combined kidney liver transplantation. And even at that time, we did not necessarily perform hemodialysis just after transplantation. We kept dialysis for patients with a delayed graft function. But I don't say there is one truth, you know, it was, we were doing, but we were very proactive. And in pediatrics, usually we have good transplants. So they don't have delayed graft function. You can push on hyperhydration, you can push on alkalinization, you can also push sometimes with hydrochlorothiazides. So it's a little bit different. I think you can also keep the safe side and do prophylactic hemodialysis, but in such a case, you just be aware not to remove weight so that, you know, you keep a good hemodynamic of the transplant. It's also very, very important. And you said that we can measure POX after transplantation, and I agree with you, but most importantly, you also have to check crystalluria and urinary oxalate regularly. We do that every week to see what we do. And we know from combined kidney liver, but also from isolated kidney transplantation, that the kinetics of normalization of urinary oxalate over creatinine ratio will progressively decrease. You know, you will not normalize that. And in weeks, it will take months. And with the combined transplantation, even years. And you really need to follow this urinary oxalate after transplantation.
Yeah. You make a great point that perhaps, or possibly, certainly the pediatric cases will be a bit different from the adult ones. I guess you find patients probably even before kidney failure, so the amount of systemic oxalosis is probably bound to be much smaller than in an adult patient who's been on dialysis for years, for example, like you mentioned. Okay, thank you. I think
may I add something, because I think it's important. So sometimes it's difficult to ask patients to drink a lot after transplantation for hyperhydration. And an adult team from Paris published in Kidney in a national letter 2 years ago showing the interest of tolvaptan, so the drug that you know very well and better than me, but the use of tolvaptan to increase diuresis to try to better control urinary oxalate after transplantation. we have only one case in pediatrics, so I don't have enough experience, but sometimes it can help to increase diuresis. At least it's been published.
That's a great point. I've seen papers with the cystinuria and tolvaptan, and I'm just about to give my first kidney stone patient tolvaptan because she's a terrible calcium oxalate patient. It's a nightmare. She has stones all the time, and nothing else has changed significantly her state. So thank you. That's a great point. Tolvaptan can help you drink more, I guess. Okay, that's great. I mean, there's so much wonderful insight that you've given us. I'm really grateful. And because we want to get to know you a little bit more as a person, to put the human side into all of this, we're asking everybody, including you, Justine, which book, 2 songs, and luxury item would you take to a desert island?
Okay, so it's a very good question that I have not really anticipated. So I'm a reader. I read every single day. I need to read before sleeping every night. So one book is not enough. So I will bring a Kindle so that I will have a lot of different books because I read, and it's my way to escape from my daily life. So, you know, I think it's really important to read, and I try to motivate my daughter to read too. So it will be my Kindle. Then the luxury item, I love bags, but I think I will take very good sunglasses to protect my eyes, and I will take fancy sunglasses.
Okay.
And then the songs, I'm kind of old for that, so I will take one French singer with Jean-Jacques Goldman, because I love Jean-Jacques Goldman, and I will take the romantic songs from Bryan Adams to listen to them.
Which one? What was the last thing you said? The romantic
Jean-Jacques Goldman and Bryan Adams.
Okay. Okay.
From the 90s. Yeah, I know.
Yeah, no,
from my teenage.
We're not judging here. We don't judge in a pinch of salt. It's all great.
Music but I would prefer books for sure.
Okay, if you're a voracious reader, this is a really tough question. I know, but could you single out one book that really changed your life, perhaps, or 2, maybe? Just, you know, 2.
Maybe not change my life, but I really like the philosophy and the spirit. It's called Le Petit Baluchon, Le Tour du Monde autour de mon petit baluchon, and it's the story of probably 50 or 60-year-old man who decided to build his own boat, and he did that, you know, in his home for years, and he prepared a very small thing, and he did he did his own Vendée Globe. It took him, I think, 3 or 4 years, and he met wonderful people. And through his boat, he was able to stop being shy. He was able to learn how to speak in front of an audience. And I think this experience changed his life, and I really liked it because I think it shows that you can do great things with small things, and probably in our context of, you know, the European context is a little bit tough at the moment, and these kind of books remind us the spirit of life. So yeah, Tour du Monde autour du petit baluchon, but it's in French. I'm sorry.
You don't need to apologize. For a long time in history, French was supposed to be the only language where you can write literature in. So it's changed, but it's still a great language to write literature in, I'm sure. Okay, Justine, thank you very much. This was very valuable. I think our audience are gonna love this. Thank you for sharing your insight. Thank you for joining us in A Pinch of Salt.
Thank you for your invitation.